Hello everyone, I am Dr. Mithilesh Kulkarni, Assistant Professor in the Department of Cardiology at UN Mehta Institute of Cardiology and Research Center, Ahmedabad. And today I would be talking about pacemaker infection, about the diagnosis and management. Now coming to the introduction, the cardiac implantable electronic devices, as we call them CIED, such as the cardiac pacemakers, implantable cardiac defibrillator, that is the ICD, and devices for cardiac resynchronization therapy, that is CRT, play an important role in the treatment of bradyarrhythmias, the prevention of sudden cardiac death, as well as in the treatment of heart failure. The use of cardiovascular implantable electronic devices, that is CIEDs, especially pacemaker, has increased in recent years owing largely to the expansion of the functions and indications for their use. A pacemaker, that is a PM, is a small device that's placed, that is implanted in the chest wall to help control the heartbeat. It's used to prevent the heart from beating too slowly. Implanting a pacemaker in the chest requires a surgical procedure. Despite the use of antibiotic prophylaxis at the time of device implantation, the rates of device-related infection may have increased according to the reports from several databases. The risk of infection associated with epicardial system is similar to that associated with the transvenous systems. Estimated risk to be approximately 2% at 5 years after implantation. So as you can see, here we are having a patient who has got a pacemaker implanted, and unfortunately the patient had a pacemaker infection, and because of that this whole skin got blackened, and as you can see in the figure, the exposed pacemaker with the necrotic skin. So this is the pacemaker which you can see, and along with that the necrotic skin. Now coming to the risk factors. So what are the risk factors for a patient to develop the pacemaker related infections? The risk of infection following implantation of a pacemaker is 0.5 to 1% in the first 6 to 12 months and rises with increasing complexity of the implanted device. The infection rate for ICD implantation is 1.7% in the first 6 months and at 9.5% after 2 years, even higher for CRT implantations. Compared with primary implantation, the risk of infection in the case of device re-implantation or revision procedures is between 2 and 4-fold higher. So as we can see, the number of infections increases with the complexity, and it also increases with the number of procedures. That is, a revised procedure will have a higher risk of infection. The infections occurring within the first year following implantation or revision are generally due to bacterial contamination at the time of surgery. It has been shown that 25% of infections occur early. When early, we mean 0 to 28 days post-operatively, 33% late, that is between 28 days and 1 year post-operatively, and 42% in a delayed manner. Delayed by what we mean is more than 1 year after the initial procedure. So we can divide the pacemaker infections into the early, late and delayed. Again revising for you, early is 0 to 28 days post-operatively, late is between 28 days and 1 year post-operatively, and delayed is more than 1 year post-operatively. So the risk factors. So here we have divided the risk factors into various groups. We'll come to the first group. The first group is patient-related risk factors. So what are the risk factors in the patient which will lead to the increased risk of pacemaker infection? So first point is renal failure. That is, a patient having kidney injury, either it can be an acute renal failure or a chronic kidney disease, both are at increased risk of pacemaker infection. Second, fever 24 hours prior to implantation. A patient having fever and who is planned for pacemaker infection within 24 hours of fever is at higher risk of developing the pacemaker related infections. Next is the corticosteroid therapy. A patient who is on chronically corticosteroid therapy, be it any form like glucocorticoid, prednisolone, is again at increased risk of infection. Next is the COPD, that is chronic obstructive pulmonary disease. Patients of COPD, that is those who are having either emphysema or chronic bronchitis, they are again at increased risk of pacemaker infection. Age more than 60 years, that is elderly patients as compared to the young patients are at higher risk of having the pacemaker infection. Malignant diseases, underlying malignancy is again at higher risk of pacemaker infection. diabetes mellitus. Diabetes mellitus, especially the uncontrolled diabetes mellitus, in which the postprandial and fasting sugar both are high, these patients are at very high risk of the infection of the pacemaker site. And also the important point is that it also takes recovery. The recovery time is high in patients having uncontrolled sugar. Next is heart failure patients. Patients having heart failure, that is acute exacerbation of any kind of like arrhythmia or heart failure, they are increased risk of the pacemaker infections. And patient on oral anticoagulation for any reason, be it AF or be it metallic valve, these are again at increased risk of infection. So again, to revise you, the patient related risk factors are: first is the renal failure, second fever 24 hours prior to implantation, third is the corticosteroid therapy, fourth is the COPD, fifth is the elderly, that is age more than 60 years, the malignant disease, diabetes mellitus, heart failure, and on anticoagulation therapy. Now coming to the surgery related factors, the surgery related the factors for pacemaker infection are: postoperative hematoma formation. Suppose after pacemaker implantation, a patient develops hematoma at the pocket site, he is having a higher risk of infection. Second, abdominal device pocket, again at higher risk. Third is temporary stimulation, that is a patient having a temporary stimulation will have a higher risk factor for pacemaker implantation. Next is the previous infection. A patient having a pacemaker and having a previous infection at any other site, be it GI or anywhere else, again will have a higher risk of pacemaker infection. The age, that is the elderly patients at higher risk of pacemaker infection. The surgery time, that is the implantation procedure, the longer the time, the longer will be the risk of pacemaker infection. The procedures which are finished early have a lesser risk of pacemaker infection. And also the perioperative antibiotic prophylaxis. It is very important to give the antibiotic prophylaxis prior, on the day, and after the surgery. So if we don't give proper antibiotic therapy, the patient is at risk of pacemaker infection. Again, to revise you all, the surgery related risk factors for pacemaker infection are: first, postoperative hematoma formation, second, abdominal device pocket, third, temporary stimulation, fourth, previous infection, fifth, elderly, sixth is surgery time, and last is perioperative antibiotic prophylaxis. Now, implant related factors. Now we come to the factors which are related to the implant. So a patient who has had a previous procedures again will have a higher risk of pacemaker infection. Lead repositioning due to dislocation. In practice, there happens that unfortunately there is a lead displacement and we have to reposition the lead. Such a patient will have a higher risk of pacemaker infection. The revision procedure. Suppose the lead has got displaced and we are doing a revision procedure, then again the risk of infection increases. The device replacement, that is the PG. Suppose we are doing a pacemaker generator replacement, that is the battery replacement, again it carries a risk. And dual chamber system. Somehow we have find that a patient undergoing a dual chamber system has a higher risk as compared to single chamber. So again, revising you, the implant related factors are: previous procedures, lead repositioning due to dislocation, revision procedures, device replacement, and dual chamber system. So what are the causative agent behind pacemaker infections? So we already discussed the risk factors for pacemaker infection. Now coming to the organisms which cause the pacemaker infection. As you can see in the chart, the responsible organisms are coagulase negative Staph aureus, the Staph epidermidis, Staph saprophyticus, Staph cephalopory, Staph lugdunensis, Staph hemolyticus, methicillin resistant Staph aureus, gram negative bacilli, Enterobacteriaceae, Pseudomonas aeruginosa, non-fermentative gram negative bacilli, polymicrobial, culture negative, MRSA, gram positive cocci, and fungi. So as we can see on the chart on the right side, coagulase negative Staph aureus is the majority cause of the pacemaker infection, that is 42%, and MRSA account to 25%. Rest are minor, but the majority are the coagulase negative Staph and the MRSA, accounting to 42% and 25% respectively. Now coming to the presentation and pathogenesis. The clinical picture of device associated infections is diverse. They may affect the infraclavicular site of device implantation in the form of localized pocket infection, or the intravascular segment of the leads in the form of device associated endocarditis. So these are the two types in which it can get affected. So as you can see, the pocket site, in the first figure there is a swelling, there is an inflammation. In the second figure on the right side we can see that the battery has come out from the incision side. Next is the echo image which shows the vegetations, and again the last figure shows the pacemaker infection, that is the arrows that are there and we can see the infection. So here are the various findings in pacemaker device associated infection. The first sign of infection may be erosion through the skin at the site of generator pocket. Persistent local pain without obvious swelling or healing of the incision may be delayed, may be the first sign. So the persistent local pain, we cannot ignore that. A patient who is having a persistent local pain at the site of pacemaker should undergo a detailed blood evaluation and also a USG local part. Aspiration of the pocket site could result in infection and should therefore be avoided. So we have to understand that while doing the culture, we should not aspirate from the site, because it will lead to the increase in infection. In patients who present with lead infection, fever and signs of systemic inflammation are usually evident and they cannot be missed. Suppose a patient presents to you with fever and other signs of inflammation who have undergone pacemaker recently, we need to rule out the pacemaker infection. The lungs may also be involved with emboli or infection. The systemic infection exhibit non-specific symptoms such as fever, chills, night sweats, malaise and weight loss. Septic shock is seen in less than 10% of the patients. Infections involving the intravascular segment of the leads account for around 10% of all cases of endocarditis. Despite appropriate treatment, lead-related endocarditis is associated with a hospital mortality rate of 6 to 15%, which is pretty high, and a 1-year mortality rate of 15 to 23%, which is again significant. Although no distinction can be made here between the effects of infection or comorbidities, but again a point to note, patients having comorbidities are at increased risk of pacemaker infection. Now coming to the findings at the implantation site, what are the local findings you can see at the site when a patient develops the pacemaker infection? Either the patient can develop redness, or he can develop swelling, or he can develop secretions, or pain, warmth, or device lead perforation. So it can be divided into local findings, systemic findings and lab findings. In local findings, again for your revision, redness is in 41 to 68% cases. The swelling, secretion, pain, warmth and device or lead perforation. The systemic inflammatory reactions are fever, that is more than 38 degrees centigrade, malaise and chills. Lab analysis, if we show the lab parameters, that is if we draw a blood and send its analysis, it will show anemia, leukocytosis and positive blood cultures. Now coming to the diagnosis of pacemaker infection. That is, we'll be talking about how to diagnose a patient who has undergone a pacemaker implantation. He is having pacemaker infection. So the diagnosis of pacemaker related infection, the diagnosis is most often, that is in about 70% of the cases, is based on findings at the generation pocket site, including the local pain, swelling, redness, drainage and skin and post tissue ulceration. Blood cultures are recommended in all suspected cases of CIED infection. A single blood culture that is positive for coagulase negative staph is usually representative of contamination rather than infection. Of the bacteria isolated, the coagulase negative staphylococci, that is 42% to 69%, and Staphylococcus aureus, that is 14 to 29%, are the most common pathogens. However, Streptococci, Enterococci, gram-negative bacteria, fungi and anaerobes can also cause infection in rare cases. At 2.8%, the rate of MRSA, that is methicillin resistant staph aureus, MRSA, is extremely low in Germany. Bacterial detection is not possible in 12 to 21% of clinically diagnosed device associated infections. Now coming to the echo, how to find infection on echo and how to go about it. The echo is able to detect the electrode or heart valve involvement, determine the size of vegetation and also quantify the tricuspid valve insufficiency. Transthoracic echo is able to assess the prognostic parameters such as LV pump function, increased pulmonary artery pressure and the presence of pericardial effusion. Now coming to the another modality of echo, that is the transesophageal echo. The transesophageal echo with a sensitivity of 96% and specificity of 90% for detection of endocarditis vegetation on leads or heart valves is significantly superior to the transthoracic examination. An echo examination should be performed as promptly as possible within the first 24 hours to note for any vegetation in the pacemaker. Approximately 45% of the CIED carries in whom the possible that is Staph aureus is detected in the blood cultures have a device associated infection, meaning that these patients should undergo a TE. So the protocol is, first we see the patient, we take clinical history, and then when he says that he is having fever or any kind of inflammation, then we go ahead with the blood investigations and the echo. First we will do the transthoracic echo, and on it, if we are having a suspicion that the patient is having a pacemaker related infection, then we go ahead with the transesophageal echo. Now coming to the laboratory diagnosis, blood sampling and determination of the leukocyte, the C-reactive protein and the erythrocyte sedimentation rate is mandatory, whereby lab inflammation markers may be normal even if infection has been unequivocally detected. A PCT plasma level of more than 0.05 nanogram per ml can predict the localized infection with a sensitivity of 60% and a specificity of 82%. Now coming to the PET, that is the positron emission tomography. 18-fluorodeoxyglucose, that is FDG positron emission tomography PET CT, can help to establish the diagnosis of a pacemaker infection. The examination is also suited to detect the septic embolization in patients with device associated endocarditis or detecting the primary source in hematogenously infected devices. The routine use of 18 FDG PET CT in suspected device associated infection is currently not recommended. Now coming to the treatment of pacemaker infection. Now coming to the antibiotic therapy. Suppose a patient comes to you with pacemaker infection and we are suspecting that there is vegetation or something. How to go about it? That is how to start the antibiotic therapy. A superficial wound infection that appears less than 30 days post-operatively, does not extend to the device and shows no signs of systemic infection can be treated with 7 to 10 day course of antibiotic therapy alone. The initial empirical antibiotic therapy in superficial infections of this kind as well as isolated local pocket infection should be initiated immediately following the sample collection. The duration of antibiotic therapy will depend on the severity and type of the infection. It will also depend on the patient profile as well as on the cause of the bacteria which is causing it. The treatment of device associated endocarditis is based on the recommendations of the European Society of Cardiology. Now coming to the transvenous lead extraction. Any infection involving the device and or intravascular lead segments represents an indication for complete removal of all foreign material. The transvenous extraction of leads with less than 1 year dwell time is generally possible with simple traction. That is, we can just give traction and remove the lead. The primary access selected for lead extraction is via the device pocket located in the infraclavicular region. If lead extraction is not possible from the implantation site, a femoral or a jugular may be helpful. That is, it is an alternative. Temporary stimulation in pacemaker dependent patients by means of an external pacemaker connected to a percutaneously inserted right ventricular lead is required and safe until antibiotic therapy is completed and a device is implanted. That is, we will be using a temporary pacemaker for a bridge through for the implantation of a new device after the completion of antibiotic therapy. Now coming to the surgical extraction, there are some patients which will require a surgical extraction. Due to the risk of the fulminant pulmonary embolism, open surgical extraction should be considered in the case of a large vegetation. By large vegetation we mean size more than 20 mm and is indicated if there is already a surgical indication due to valve endocarditis. As possible focuses of infection, implanted devices and leads should be removed during surgery for heart valve endocarditis irrespective of whether they show signs of infection. Now coming to the reimplantation. Suppose a patient comes to you with pacemaker infection. We suspected infection, we confirmed the infection, then we gave the antibiotic therapy, we have removed the pacemaker, then when should the reimplantation be done? The indication for renewed implantation needs to be revived critically using long-term ECG or telemetry monitoring. The timing of reimplantation depends on the severity of infection as well as the responsible bacterium and can only be performed once adequate antibiotic therapy has been completed. That is, after the patient has become asymptomatic, then only we can do the reimplantation. Now various tools which are used for lead extraction. The figure A shows a locking system, that is a locking stylet which is inserted in a right atrial lead, is used to stabilize and lengthen the lead. A right ventricular lead and an occluder in the left atrial are visualized as the secondary findings. Now coming to the figure B, now mechanical polypropylene extraction sheets which are available in a variety of sizes are advanced to the tip of the ICD lead to be extracted in order to disrupt the adhesions. A temporary catheter in the right ventricular apex ensures stimulation in pacemaker dependent patients. Now coming to the figure C, that a mechanically controlled extraction sheath, a rotation blade at the tip is used to extract the right atrial lead. And figure D shows snares are used to extract the leads via a femoral or a jugular approach. An ICD lead trapped in the RV is extracted via the right jugular approach. Leads in the RA, the Seldinger wire in the left subclavian vein to secure the vessel lumen. Now this is a very important chart and we have to go through it to how to approach a patient who is having a pacemaker infection. Suppose that we are suspecting a patient who is having a pacemaker infection, then we'll take the clinical history and we'll also send the lab samples. In the lab samples we'll be sending the blood culture. Suppose if the blood cultures come out to be positive, then we'll do a TE. Now in TE there are three possibilities. Either there is cardiac valve vegetation, lead vegetation. In these two cases, that is when there is cardiac valve vegetation or lead vegetation, then we have to do complete system explantation. For that we have to give antibiotic coverage for 4 to 6 weeks in the case of cardiac valve vegetation and 2 to 4 weeks in the cases of lead vegetation, and ultimately we have to re-evaluate the patients, the negative blood cultures, and then we have to consider the reimplantation. Suppose a patient develops a negative TE, that is we are not able to see the vegetation on TE, then the complete system explantation is to be done and antibiotic therapy is given for the 2 weeks. Again re-evaluate the patient and then we have to re-implant it. Suppose the blood cultures come out to be negative, we do a TE. If there is evidence of pocket infection or perforation, then if it is positive, that is there is evidence of pocket infection or perforation, then complete system explantation is to be done, followed by antibiotic therapy for 2 to 14 days, follows by re-evaluation of the patient and then re-implantation. Suppose there is no evidence of pocket infection or perforation, then we have to do close clinical monitoring, that is we need not extract and re-implant the device. Now coming to the prevention. The risk factors for the development of device associated infection need to be minimized properly. As we had summarized in the first slide, we need to control the sugar, we need to control the creatinine, we need to control the infection, and proper monitoring of everything is to be done. The preoperatively antibiotic therapy significantly reduces the infection rate and as such should be administered in all procedures. An absorbable antibacterial envelope that encases the device and extravascular leads and releases antibiotics to the surrounding tissue showed a risk reduction of 71%, which is significant, for the development of infection in a meta-analysis. Now coming to the summary of the pacemaker related infections. The CID infections are becoming ever more frequently and without adequate treatment are associated with a high mortality, which is important to note. Diagnosis can be challenging due to diverse clinical picture of infections, and one always needs to rule out involvement of other cardiac structures. Definitive treatment consists of complete removal of the entire system, which can be performed safely and successfully in specialized centers using a transvenous approach. Device reimplantation is not necessary in all patients. However, when required, it should be carried out on the contralateral side following adequate antibiotic therapy over a sufficiently long period of time. Thank you.